Problem Gambling Foundation's Prisons program and the research that you two have done around what's currently happening in prisons is genuinely interesting to me anyway. I hope the rest of the audience find it so too.
Hi everyone, can you hear me okay? Yep, great. Thank you for coming. I do appreciate that it's 4:30 in the afternoon and you're probably knackered. Hopefully you had a lot of coffee at afternoon tea and I'm not going to put you to sleep. I'm sure if I do, Robert will wake you up when he comes in halfway through. So basically we're going to talk to you today about a research project we did. It was about the provision of problem gambling services in New Zealand prisons. I just want to start off with a few acknowledgements. Two of our colleagues who were integral to this project, Professor Brian McKenna and Dr. Claire Gooder, can't be here with us today, but we're thinking of them anyway. Also, the research involved a lot of problem gambling service providers throughout New Zealand. We really appreciate the time they put into this. We couldn't have done it without you. Department of Corrections staff, we had an expert reference group who helped give us advice throughout the project. Ministry of Health for funding the project, and of course Department of Corrections for allowing us to talk to their staff and other things that they did throughout. Okay, just to quickly talk you through the methodology. This project was a mixed methods research project. The first phase was a literature review. I'm not going to go into that too much. The second phase was a policy review where we did a stock take and review of the national, regional and local prison-specific policies for problem gambling interventions. So really we were looking there for policy objectives and guidelines as to the provision of services within prisons. The third phase was case studies, where we looked at two representative prisons. The first of these was a men's prison which catered for 600 plus prisoners. It was a minimum security prison that had a work and pre-release unit. The second prison that we looked at was a minimum to high medium security women's prison, and this had around 200 prisoners, and it included a baby bonding unit, so quite different prisons there. Following that phase, we did a fourth phase, which was national surveys. This was two complementary national surveys of prison staff, the first one, and the second one that looked at problem gambling service providers. Both of these were web-based and they were anonymous, and we had really good response rates for both of those. So I'm just going to walk through some key findings here. The literature review, pretty basic findings anyway. There's a lot of research out there, but it's very site-specific, tended to be case studies in individual prisons, so not that applicable to a wider audience. CBT, or cognitive behavioural therapy, was cited as an effective intervention approach. Most interventions were beneficial compared to no treatment, and I think that's coming out again and again in treatment research, so doing something is better than doing nothing. And one that was really relevant to this piece of research, and we'll both touch on this a bit later, is the importance of multiple points for screening and or intervention. So in terms of prisoners, doing screening and interventions prior to sentencing, at the start of imprisonment, during imprisonment, prior to release, and during re-entry into community. So a multi-stage, multi-pronged approach there. Okay, so the research outcomes, there's two key bits. I'm going to talk about the first one, which is a framework which describes the provision of problem gambling services for prisoners, and Robert's going to talk about the development of a best practice model. With the framework, there were four key phases, and what I can say is that it became really clear to us early on that nothing was clear about what was going on in prisons in terms of interventions. It was really hard to figure out who was doing what, how it was happening, where it was happening, when it was happening, why it was happening. It was just really complicated. But we managed to pull together this framework. There were four key phases. The first, obviously, around screening and preliminary assessment. The second was around referrals. The third around interventions, and the fourth was follow-up and continuity of care. And that sounds really simple, and I wish it had been that simple to figure out. Yeah. Okay, so I'm going to talk through each of those. In terms of screening and preliminary assessment, the responsibility for these rests really with prison staff. So it's out of control of treatment providers. The prison staff tend to use the problem Gambling Severity Index, which is also known as the G9 or the 9. It can be completed by the probation officer during a pre-sentence interview, but it's always completed, maybe in addition to that, by a prison sentence planner when they're developing an offender management plan. So the offender management plan is basically figuring out what issues a prisoner is facing and putting a plan in place as to how those are going to be addressed throughout their sentence. The G9 was considered to be easy to use and quick to apply. So, there were some difficulties with screening that were identified by the people that we talked to. The difficulties with screening. Both prison staff and service providers considered that the G9 failed to detect problem gambling in some prisoners, so it wasn't always 100% accurate. The difficulties around this, people thought really that prisoners sometimes didn't understand the items due to language difficulties. Sometimes they thought that it was culturally inappropriate. It was also thought that prisoners sometimes misrepresent their situation, perhaps through a desire to manipulate the system, a reluctance to disclose around their gambling problems, and perhaps a lack of self-awareness of their gambling problems. It was also thought that the gambling problems were often overshadowed by other priority issues, so things such as drug and alcohol addiction or violence were considered to be much more important than gambling, so gambling would slip down that list of things that maybe we'll address if we get time and if we get around to it, but we're definitely going to look at drug and alcohol and violence first. So, some proposed solutions that came out of the research from the people that we talked to about how to improve these screening processes really focused on, like I was saying earlier, that repeated use of screening, so using the G9 repeatedly throughout the sentence. So not just at the beginning, not just at the end, but right throughout, giving you a tool to sort of measure progress, to measure what's going on with that prisoner. Emphasising that the G9 is a screening tool only, and that positive screening can use a structured interview and other collateral information gathering. The more points of information that you gather, the more likely you are to get a full picture about what's going on with that person. And a really, really big one was around improved communication between prison staff and problem gambling service providers. And I'll touch on that one again in a minute. So the second phase, if you remember, there was that 4-phase model, was around referrals. So in terms of what we heard from prison staff, basically referrals are organised by them. It's usually done as part of the offender management plan. And they generally believed that this referral system was working really well. They thought that it was comprehensive, they thought that it operated smoothly and in a timely manner, and they saw no reason to exchange the existing system. They were quite happy with how it was going. They were aware, though, that sometimes referrals were initiated outside of their offender management plan, and that this could be done either by prison custodial staff, could be done by prison psychologists, or it could be done by a prisoner directly approaching a problem gambling service themselves, either through telephone access, or it might be that they had contact with a clinician prior to going into prison. On the other side of the coin, we've got what the service providers told us. They had a really limited understanding of the referral process. It was a bit of a mystery to them as to when corrections staff and how corrections staff decided to send through a referral. They couldn't understand quite how it happened. Sometimes soon, sometimes not. It just, was all a bit of a mystery. And not surprisingly, they felt pretty disconnected from that referral process. They were really concerned that a number of problem gamblers were missed by this process. And they felt that there's a lack of communication about the screening results. So when they did receive a referral, they knew that the G9 had been administered, but they weren't given the results of that quite frequently. And not surprisingly, they expressed some doubt about the effectiveness and the efficiency of that referral system. So you can see two quite different perceptions. One thinks it's all going swimmingly and we don't need to change anything. The other side, not quite so convinced about that. Okay, so solutions for improving referrals. There were 3 key areas. Prison staff, I should acknowledge that at the time of this research, when did we do it?
2010.
2010 to 11. Department of Corrections were making a lot of changes, and prison staff thought that these changes would address any shortcomings in the present process. Service providers saw that there was a need for prison staff to be more supportive, and both prison staff and providers saw a need for better communication. So again, that communication is really key. Bless you. Okay, the third one around interventions. The clock's gone, there it is. Okay. So the timing and priority of interventions is determined by Department of Corrections policy and individual prison requirements. And this results in a really challenging environment for service providers. Operational considerations mean that prisoners are not often interventions into latent incarceration. We talked to a lot of clinicians who said they didn't know if they were going to make an appointment, show up next week, if they were going to be able to see that person. They might have been transferred to another prison. The prison might be in lockdown. There are all sorts of reasons that it was a really hard environment to work in. Plus, they were not always felt particularly welcome. The intervention process itself is obviously the domain of service providers, and they were using a range of interventions from things like CBT through to coping strategies, motivational interviewing, reflective diaries and relapse management plans. And of course there was a focus on intense, short, self-contained one-on-one sessions with specific goals rather than long-term counselling. And again, that was a practical focus, I think, because you didn't know if you were going to be able to see that person. This might be the one time that you get to see them, and then they're transferred down to Dunedin, and Thomas has got to try and get access to them again. Okay, so in terms of improving the intervention process, interestingly, both prison staff and providers thought that a general health education approach would be really useful. They thought that education, though, wasn't sufficient and that it had to be combined with targeted interventions. A lot of people told us that within the prisons, the staff, they were not really aware about problem gambling issues, and just some education around that would help them believe in what was happening and what was being provided, and therefore they'd buy into that more. Again, that communication between the two parties. The fourth point, and then I'm going to hand over to Robert, is around follow-up and continuity of care. For the majority of prisoners who are serving less than 2 years, and that's quite a big proportion for prisoners, wasn't it? Yeah. There's no provision for systematic follow-up to address problem gambling needs. Once they're released from prison, they're on their own to a large extent, in terms of readjusting to society and all those things that go along with being in society, access to gambling, access to alcohol, all the other issues that they were facing before coming into prison. And both prison staff and providers did acknowledge that there was a lack of follow-up and support that was available. So one thing that people talked to us a bit about was around service providers being involved in pre-release assessments and planning, and that would really help with that continuity of care. Also developing systematic patterns of community referrals, so this would help contribute to the continuity of service occurring in the prison. So if you're seeing someone before they go to prison, being able to continue seeing them while they're in prison, and then when they come out of prison if that support is needed. Yeah, I think that's about me.
Okay.
Over to you.
Fiona's been really good. She's covered pretty well everything. But using the information, the findings we got from the study, we then, well, the two things that we did in the study that I think were useful. One was developing that framework of screening, referral, intervention, and follow-up. Just developing, as Fiona said, there didn't seem to be any systematic or rational logic in how the system worked in prisons. It was very haphazard, so we felt it was quite a step forward to be able to develop a 4-stage process that we could encourage the prisons to follow. But in terms of developing, the other thing was developing a best practice model. In terms of developing that, it's important, we think that to do so, we must address the challenges that the prison environment provides. And these are, as Fiona's mentioned, I think, security issues, like security is a major thing in the prison, rehabilitation or intervention comes a distant second. Transfer of prisoners from one prison to another for various reasons, like they may, long term, they may go to, say, Dunedin or the prison farms. and they may then at some stage come back for a further court hearing if they have further charges. There's disciplinary procedures if prisoners misbehave or don't behave, so that they're not able to attend programs. And overall, there's limited access to programs for prison inmates. There's the stresses of being in a prison. I mean, it's stressful. I don't know if you've ever been in a prison. Certainly, I know Thomas has. But it's not a pleasant place to be. It's not a place you choose to spend time.
I always got out at 5 o'clock in the evening.
You were lucky. I've been kept in longer than that sometimes. You have to behave. And the whole prison culture can be negative in terms of trying to achieve things. So, and there's sometimes in some institutions, some prisons especially, there's a kind of apathy, both prisoners and staff. And of course then there's relationships between prisoners, staff and the external providing agencies. So all those things are have to be addressed if we want to develop a better model, best practice model. And the challenges impact on two things mainly. One, the accurate identification of problem gambling among prison inmates, and the other thing is, of course, the actual intervention, the provision of appropriate services to that inmate. So in order to address these challenges, it's important, the most important thing we think is to improve communication between prison staff and problem gambling service providers. There's got to be an increased awareness and a greater respect for each other's philosophies, cultures and the objectives. As I say, the prison objective is security and humane containment, whereas the problem gambling group providers, their primary objective is to sort of build a relationship with the inmates and to get some change in the gambling or problem gambling behaviour. So it's really important that we develop that kind of relationship rather than, I mean, when you talk to problem gambling providers, you are told in many cases, in some cases, that they've got great difficulty in gaining access to the prison, but even when they're in there, they feel a lack of support or cooperation by the prison staff. And among prison staff, when you talk to them, while they might quite like the individual therapist, for them arranging and providing access to prison inmates is an added sort of chore. You know, they've got enough to do, keeping an eye on these guys and making sure that security is okay. But when you get official visitors come in and they want to see people and they want to spend an hour with them or 2 hours with them, it's just an extra chore for the prison staff to consider and deal with. Faster.
10 minutes.
There's only a couple more, don't worry. The other thing is that it's really important, and I think this came out in a couple of papers this morning, that the cultural background, the cultural environment of problem gamblers is adequately considered and taken into account in both the screening and the intervention process. I mean, we're well aware that over 50% of the people in New Zealand prisons are Maori or Pacific peoples, and yet things like the G9 are you know, Pākehā, European type things. The Department of Corrections itself recognises that it's important to address the cultural needs and rehabilitation to reduce risk of reoffending in the future. And as I say, for example, one of those things is that the possible misunderstanding or different interpretation of items in the screening test for different ethnic groups. And of course, there's a substantial difference in the cultural appropriateness of family and whānau involvement in provision of intervention services. So it's important to address that. The other issues that are important to address are the timing and the type of intervention. Fiona mentioned that it's better to do something than to do nothing. But even cognitive and CBT approaches, which are far and away the most widely used approaches, there's limitations in their effectiveness among problem gambling individuals and problem gambling prisoners. It may be impacted by the comorbidity, such as marital problems, substance abuse, financial hardship, social isolation, relationship problems, and for many problem gambling prisoners, immigration and employment issues. These issues are important for problem gambling prisoners and really have to be acknowledged and addressed. And again, following on from what Fiona said about screening at as many times as possible, really, throughout the prison sentence. In most cases, I think prisoners are meant to be screened either pre-sentence, pre-imprisonment by the probation officer, or within, I think it's 28 days of actually the sentence. I think for longer, that's for prison inmates with sentences less than 2 years. For inmates with sentences over 2 years, it may be up to 60 days before the actual screening and referral process occur. And again, best practice would suggest that the referral and intervention happen as early as possible. I think Krebs, as it says, that intervention is by far the most effective the earlier it can occur in the sentence. So many of these people don't actually have that opportunity, and in fact, as I understand it, there's probably a Department of Corrections philosophy or policy that if the person's in for a longer period, let's say over 2 years, then the actual intervention may not occur until sometimes toward the last 6 months of the sentence. Our research suggests that best practice would incorporate early screening with referral intervention and multiple reviews throughout the sentence, and the continuity of intervention and support on release of the prisoner into the community. Again, if it's a 2-year plus sentence and there's parole board hearings involved, then that support on release into the community is likely to occur, because that'll be one of the conditions probably of the release, the parole release. But for the vast majority of prisoners who are less than 2 years sentence, there's no such condition. So as Fiona was saying, they just end up going out into the community, and it's only good fortune if the therapist they've been seeing in the prison can then continue contact and continuity when the prisoner's released. So what we've got overall is that for best practice, we really need better communication between prison staff and problem gambler providers, and increased awareness and mutual respect for each other's philosophies, their culture and their objectives. Next point is that there ideally would be thorough incorporation of cultural needs within problem gambling service provisions. That's at the screening, referral, intervention and follow-up stages. That we'd have earlier screening with referral, intervention, multiple reviews, and a continuity of intervention support on release. Then additional to those three essential elements, we think that some public health education on problem gambling for all prisoners and staff would be useful and give a greater awareness, so that, as Fiona was saying, that problem gambling isn't sort of lost in the flux of other problems like alcohol and drug abuse and violence. It'd be ideal for both prison staff and service providers to be involved in the assessment and release planning for the problem gamblers prior to release, and to also hopefully be involved in the regular follow-up support. And of course, as in everything, it'd be great to have some evaluation of treatment effectiveness with offenders at post-release follow-up. So that's basically where we came to. That was our second finding, and I think that's it. We've got a list of where you can find things. Okay.
Kia ora kōrua, mō tēnei kōrero. And we have a little time for some questions, if anybody has. Leanne.
I just wanted to check, I'm assuming corrections source,
Yes.
and this was done in 2010.
2010, 2011.
On Myanmar, I do quite a lot of work in county prisons, and it's lovely to see this, and where we are now in 2014, because I think it was heard, because there's in Canada, and what's happening for us, I think, my knowledge nationally that corrections are really embracing everything that you've put down in that research. I go and I feel quite welcomed, they want to embrace us, and it's really positive. It's nice to see us shifting, so it's nice to see it in 2010. Also, around being inclusive, I think we have to be careful that we don't see us as the main support, and within that environment, building those family connections before release rather than trying to do it afterwards. That's something I've got feedback around.
That's a really interesting point, because one of the things that providers have said is that you have to get approval, to have a family member visit the prisoner in terms of problem gambling. It's difficult. Yeah.
Well, I've just done 14 interventions before business, so they're open to it, provided that it's done in the right way with all those essential services and case managers, and it's done in a safe way.
Well, that's great. There's greater communication between the two cultures.
Thank you, Leanne. Another question there?
Well, I was just going to ask if you have, or anybody has any ideas about how you can improve communication, because there are many levels at which that could be addressed. It could be addressed at an interdepartmental level, it can be addressed at an agency level, and what usually happens is it's left to be addressed by the worker, what I call what I call the shit kickers of the organisation. It's usually right down the bottom with you trying to coordinate your work with the specific person in your specific jail who is most likely to refer people to you. That's I don't know what the New Zealand situation is like, but that's how it is.
So just in response to that, actually, one of the problems, so at the call phase, we found that that's where we get the biggest success. And at the national level, that is problematic at two levels, the multiple points of screening, which is that one, it implies that someone didn't do a good job in the first place, so it's offensive. Why would you need to do it a second time? We've already done that. The second point that makes it quite unsavory for them to do the multiple points of screening is that it in some way may take into account that gambling problems develop while they're in prison, and that's not particularly a tasteful acknowledgement. So that's where I probably see a lot of the difficulty. And so I've actually been impressed. So Thomas, Leanne, I mean, my head is absolutely off, because that has been cold-faced development, the relationship, and is really not significantly impacted yet.
That's interesting, because the Department of Corrections is a big beast, if you like, and there's sometimes quite a disconnection between head office or even regional and what happens in a particular prison. And the point you're making is that you can work really hard and get some progress with individuals in particular prisons. But then those people might change and you get someone else who may or may not be amenable to what you're doing. So there's lots of areas where it can be problematic.
I think that sensitivity became very clear to us as well when finishing the report and corrections being allowed to have a look at that, and yeah, there was a lot of
Taking a long
sensitivities
time
around
and a lot of things they didn't like it was phrased, and the fact that they were embarking on a review of their rehabilitation approach about that time was seen as, that this could be possibly critical of what had been happening before.
Okay, I've got a question over here.
How much active gambling goes on in prisons? It must be
Good question.
increasingly easy.
It depends who you ask. There used to be a lot more when cigarettes were freely available.
I suppose it's like inflation.
Sorry.
I mean, just mean by, we're all increasingly connected. Imagine it's getting increasingly easier to bet in a mainstream way.
next research project. Yeah.
There's lots more to find out.
Could I just put something in there? A research project around the actual prevalence of gambling in prisons would be a very useful thing. A question there, sure.
Yeah, thanks, Rob, Fiona. The mental health assessment tool that's just rolled out in the last 12 months, has that got gambling in it, or is it regarded as not a mental health problem?
I don't know, sorry.
Hopefully it has.
Pardon?
Hopefully it has, Sean. But
I just thought it might have a systemic way of being able to screen everyone and take it on board as an integral part of what they do. I can't seem to get a copy of it.
One more question?
I was just going to comment that there are statistics available, most up to date on gambling in prison. I just can't quite remember which report. I don't know if it's the National Mental Health Surveys of prison mental health or not that I got that information from, but it's certainly available. I just can't quite think of the report.
that's referring to
Gambling in prisons.
current gambling, not prior to being in prison. Because a lot of the G9 questions refer to what were you doing in the last 12 months. The person may or may not have been in prison at that time.
I think it distinguishes remand and long term, I think, from memory.
That's interesting because the Department of Corrections seems to be opposed to providing any screening or any intervention with remand prisoners because they haven't been sentenced yet.
Okay, just to keep to time, and just if people are interested, just before I ask you to show appreciation for Rossen and Fiona, if this does interest you, we're doing a presentation. I coordinate Problem Gambling Foundation's prison program. And we have a presentation from 12 to 12:30 on Friday, and interestingly, the starting point of that is the different cultures between a justice department and a health service. And Section 125 of the Corrections Act says that prisoners are entitled to health services comparable to what they might receive in the community. So that is the starting point. And so if how we've worked with that, if that interests you, you're welcome to come along. And I couldn't resist the fact.
We can expect great progress with Peter Dunn being Minister of Health and Minister of Internal.
Indeed. So if I could ask you to show your appreciation.